Hello everyone, and welcome back again. I will go over vital signs, and I will say this is part 1. I'm not sure how many parts we will have, but this is vital signs part 1. Please have your book, Cozier and Herb's Fundamentals of Nursing, available, as I will reference a lot of things to your book. Here are our objectives. Always remember the power of knowledge. Never underestimate the significance of vital signs. It could be your sign that something is happening with your patient. Before we talk about why do we do them meaning vital signs, I would like for everyone to pull out their book and turn to page 477. That would be chapter 29, page 477, where we will begin to speak on vital signs. Why do we do vital signs? Look at all of the bullet points. When I take vitals, I know it's my baseline data for what I need to first initially determine what is going on with my patient. Is my patient stable? Is my patient unstable? Look at these 4 bullet points. Indicates response to physical and psychological changes. Your vitals can change in many, it can change for many ways. What's going on with the patient having pain, is the environment cold, can change your vitals, is stress happening, different things can change the patient's vitals. As we see here, vital signs reflects the body's physiologic state. So look at the things that we look at for vital signs. The temperature, pulse, respiration, blood pressure, and believe it or not, pain is the 5th vital sign. And in your clinical settings, you will also add on the oxygen saturation. Now, sometimes I'm asked, well, Professor Roberts, how often are we to take vital signs? Well, I pulled this blurb out of your book. When and how often to assess a specific client's vital signs are chiefly nursing judgments depending on the client's health status. Sometimes we read this paragraph as I speak. Sometimes we get doctor's orders that say vital signs every 4 hours. In ICU, it may be vital signs every 15 minutes. So it just depends on that patient's status, what's going on, and your nursing judgment. Even though it may say vital signs every 4 hours. But if you personally feel you need to take vitals more frequently because you just have that nursing intuition, I probably need to take his vitals every 2 hours because his temperature keep going up and down. You can do that. There's no harm in doing it. It's just you have to make sure that you don't take it every 5 hours if the order says every 4 hours. But you can take it more frequently. I hope that understands. And I got this little area from in box 29-1 on page 477. Now, as you see on these 2 bullet points, because I talked about the others already, can someone else do vital signs for the nurse? Well, of course. We can delegate. We can delegate vital signs to the LVN. We can delegate vital signs to the CNA. Where does the responsibility of those results lie? If you're the registered nurse and you're delegating, you should always reassess your patient and go and make sure that the circle has been complete. So when I say the circle has been complete, patient needs vital signs, beginning of the circle, you delegate to Susan. Susan does the vitals. Susan documents. You follow behind Susan to make sure the documentation is there. And if there was anything abnormal with the vitals. Let's look at this slide as we talk about temperature. And I'm going to gear you back to page, I believe it's 478, as we speak about temperature. I would like for you to look at radiation, conduction, convection, evaporation. See how those relate to temperature in your book. Now we know that the balance between heat gain and loss in the body is regulated by, of course, the mighty hypothalamus located in the brain. excuse me, we have to be careful with our newborns and our elderly because these patients have deficiencies in their thermal regulation. So the more sensitive to the environmental changes because maybe they have less adipose tissues. Their body, the little one's body has not adapted to adults. But as older adults are, which is considered your elderly, but we're going to use the proper terminology and say older adults, a lot of times the adipose tissue, they don't have as much. And look at our women. Women experience greater temperature fluctuations. Now go to your book, and I'm going to refer you back to your book, and I'm going to show you the page. Now I'm going to slide through your page in your book for the sake of time, but look at the basal metabolic rate. I want you to look at that and see the difference between these two and what is happening. I also want you to look at muscle activity, thyroxine output, epinephrine, norepinephrine. Look at the bold and look what it's speaking of. With these hormones, here on number 4, these hormones immediately increase the rate of cellular metabolism in the body. What about fever? Of course, fever increases cellular metabolic rate, and thus, what does it do? Increase the body's temperature even more. Now, when we slide down as we talk more about temperature, I'd like for you to look at radiation and conduction and convection, like I said earlier. But as you slide down your pages, look right here in this area on your page. Shivering increases heat production. Sweating is inhibited to decrease the heat production. Oh, I feel hot. Your body is trying to cool you off. Vasoconstriction decreases heat production. Now look right here. That old little hypothalamic is right there again. What does it do? It controls the core temperature. So we always want to look at that and the temperature of the patient and what is going on. So after you read that information, now you can put it together and understand our core fights to maintain +1 to -1 degrees of at all times your temperature. Temperature receptors throughout the body communicate with the hypothalamus, as we saw that earlier in your reading. Look at these factors and how they affect the temperature. I'll speak on some later on. Now let's talk about temperature. Normal temperature, 97 to 99.5. In your textbook, I will tell you, your normal temperature on page 479, which I will go by, says in your textbook 96.8 to 99.5. And that would be 36 degrees Celsius to 37.5 degrees Celsius. Now, as you look at this slide, go ahead and review it. I want to add some information as I viewed the ATI, the same ATI that you viewed. Now, I want you to know ATI is slightly different with their normal ranges, but we're going to go with the normal ranges that's in the textbook. Now, but also know that I agree with ATI when it says the rectal temperature is either 0.9 degrees Fahrenheit or 0.5 degrees Celsius higher than the oral. So if your oral temperature is 98 degrees Fahrenheit, that means if you would have taken it rectally, it's really 99 degrees Fahrenheit. And your axillary and tympanic temperatures usually 0.9 degrees Fahrenheit to 0.5 degrees Celsius lower than your oral temperatures. So if it's oral, it's 1 degree. Basically, that 0.9, I like to just say 1, but let's go with 0.9 degrees higher. Then if you take it orally, it's, if you take it, higher than oral, the rectal. And then axillary and tympanic temperatures, 0.9 degrees Fahrenheit or 0.5 degrees Celsius is lower than your oral temperatures. I do have the formula to convert Fahrenheit to Celsius and also to convert Celsius to Fahrenheit. Let me know in class if you need that, and I will let you know. Now I'm switching back over to your book. I wanted you to also add on to the factors that affect the body temperature. Number 1, age. Number 2, look at number 3, exercise and hormone stress. I want you to look at those. These are all things that affect the temperature. Okay? As we continue on in the lecture, I want you to focus on heat exhaustion. Read the area about heat exhaustion and heat stroke. Please know the difference and know why these patients are having heat exhaustion and heat stroke. I want you to look at the clinical manifestations of fever. I'm going to scroll through and I want you guys to see you have the shivering in there, complaints of feeling cold, the goose flesh, that's the appearance of the skin. Okay, this as they continue on, they plateau phase. They start going through these here. Okay, just read all of those and see what these patients are going through. Then you have the fever abatement phase, and that's when the skin appears flushed and feels warm, sweating, decreased shivering, and possible dehydration. Please look at this slide for our nursing interventions of what we would do for a patient that has fever. All of these points are very important. Please take notes if you want me to speak more on any of these. I will be happy to do it in class. I wanted to break down some words for you. Pyrexia, as you see at the top of the slide. A body temperature above the usual range is called pyrexia. Hyperthermia, or in lay terms, we say fever. A very high fever such as 41 degrees Celsius or 100.5 degrees Fahrenheit is called hyperpyrexia. You can find this information on page 479. And then the client who has a fever is referred to as febrile. The one who does not is afebrile. I wanted to touch on that. Now let's talk about hypothermia. Look at this slide, but please bring your book along as I'm going to reference to the book. Now look on page 480, right lower corner, hypothermia. It's a core body temperature below the lower limits of normal. The 3 physiological mechanisms of hypothermia are excessive heat loss, inadequate heat production to counteract heat loss, and impaired hypothalamic thermoregulation. Please read this section on hypothermia, especially induced and accidental hypothermia. It's all in this area. This slide reviews some clinical manifestations that you might see or the patient might complain of. Taking vitals, they may become hypotensive. Checking their orientation status, they may be disoriented or drowsy. Their skin, pale, cool to touch. You know how we use our fingers for touching. Patient might be shivering. And of course, we're going to check their body temperature, their pulse, and their respiration. Please look at this slide for more considerations. Very important. I need you to make sure you really look at each of these bullet points for the considerations of the patient. Please pay close attention to this slide and the time. Also with this one, the red and the blue, know the difference when you pick it up, meaning the thermometers. I didn't want to leave out in box 29-3 what we should do as a nurse. These are our interventions for patients who are experiencing hypothermia. As we come to a close on temperatures, please read through here as I scroll down and refer to your ATI for the video for placements and the types of thermometers. Thank you for listening and stay tuned for part 2. Just want to scroll through. I know I told you 15 minutes, but I wanted you guys to see this. It is in your book. It is in ATI, but I don't want to go over 15 minutes because I want to keep your attention. So, but this is in your book, and you can also see it in ATI. Thank you so much again.